Well, thank you for the opportunity to be here. I always enjoy an opportunity to speak about blood flow restriction, given our BFR Masters webinar series. If this is going to, yeah, I don't know why I can't. Okay, beautiful. Of course, technology doesn't work. Um, so why are we here today? Well, really, it ultimately comes down to the demand for BFR training is growing. It's not if, it's when. And you need to be ready for the amount of referrals and the physicians that are going to be driving this demand. And we'll talk a little bit about that later in a pivotal study. And so my name is Dr. Nicholas Rolnick. I am a physical therapist, personal trainer, and the co-founder of the BFR Pros. I've been a personal trainer for over, oh my gosh, now it's 2022, over a decade, almost going on 11 years. I've been a physical therapist for 5. And, I love every day. I live and breathe helping people get back to the activities that they love as quickly as possible and use proven evidence-based therapies such as blood flow restriction in my rehab and performance plans. Do I use it all the time? Absolutely not. But understanding when you can apply this technology to maximize your outcomes is essential. So what else besides the BFR Pros, me being, a meathead personal trainer, physical therapist? Well, I teach undergraduate exercise science as well as a clinical internship class at CUNY Lehman uptown in the Bronx. If anybody has been to New York City, the Bronx is up there. I'm glad that I don't have to go there in person anymore. And I've converted my class to online, which is incredible. So thank you to COVID for at least that. I also adjunct and I teach in the master's and PhD program at Concordia University of Chicago. I teach strength and conditioning and applied kinesiology and anatomy. And I was recently appointed to adjunct faculty at New York Medical College, which is a physical therapy doctor of physical therapy program out in Valhalla. I'm basically their go-to BFR resource, helping design studies for the students, and hopefully, the end goal would be publication. Speaking of publications, I am actively involved in the research. So not just somebody who is telling you about BFR and its benefits, but I am actively investigating and reporting on said benefits. And one of the missions of the BFR Pros, as BFR continues to grow, we are an unbiased education company. What does that mean? That just means that nobody's lining my pockets or the company's pockets, telling us to promote certain technologies because it's in their financial interest. Our financial interest is providing the best world-class BFR education, and we take that very seriously. We are not just rehab providers and clinical educators and instructors, but we are all actively involved in pushing our understanding of blood flow restriction further than when we actually, got into the field. And I think a lot of people are getting into BFR because it's a hot topic. It's, judging by the interest, if you look at Google, you can start to see that there are ticks in terms of searches on blood flow restriction, BFR training. It's all going up. And we want to be that entity that is trusted worldwide for blood flow restriction training. And we take that very seriously. And so I've currently been published 9 times right now. I've had 3 articles even published this year. On the right is one of the more current articles that is about to be published. But a lot of times as BFR continues to grow, clinicians that reach back out to me that have taken my in-person workshops, taken courses from other providers, whatever, they don't really understand one of the barriers, which is how do I screen an appropriate patient? So we initially wrote up a paper last year called Perceived Barriers to Blood Flow Restriction Training. And I wrote that with a couple of other guys that teach for Owens Recovery Science using the Delphi unit, and paired with a couple other researchers. And we introduced this screening algorithm that basically takes clinicians through a pertinent thought process that they should be aware of as they're trying to determine an appropriate BFR candidate. But that paper did not talk about specific medical diagnoses. It was very, here are the thoughts. I want you to understand this thought process. This is going to help you because it helps us. Boom, boom, boom. This paper that is about to be published goes through medical diagnoses like hypertension, diabetes, chronic kidney disease, COVID infection, individuals that use anabolic steroids or ergogenic aids, cardiovascular disease. And we try to introduce a screening tool specifically for those conditions. So when I say that I am not just here to talk to you about BFR, because, you know, it's a business that I'm in, BFR pros, whatever. It really is. I've seen it change lives. And when used correctly with the appropriate patient, it can really accelerate your practice and grow your referral sources in terms of word of mouth, but as well as successful, happy patients. And this paper, which was a beast, incredible amount of work, should be published in the next couple weeks, 2 weeks or so. They're lagging on getting the partial funding, whatever. That's just public, open access publication stuff. But the thought is, again, I practice what I preach. I'm here to give you information that you can then integrate into your own practice so BFR can continue to grow safely around the world and in places like Canada. What else am I? I am a Frenchie owner ×2. These are my two Frenchies, Ruby on the upper left and Ryder, who we just got, my girlfriend and I, we just got on Sunday. And he's getting a little bit of life lessons right now because Ruby has been a single COVID dog. And I don't know if any of you listening right now have had got a dog during COVID, but we were always around. And I've always grown up with dogs, and I wanted a second dog almost immediately after I got Ruby, just because I knew that that was going to enhance her quality of life. And so here we are with the two Frenchies, and I honestly couldn't be happier. They are the best. So happy. So when I am home, it's great because I am home a decent amount, splitting time in the clinic, but also writing manuscripts and now caring for a young pup, which is usually behind me, but I think my girlfriend has her for this webinar. So anyways, I want to start out with kind of setting the stage for what kind of how have the last really 5 years been in terms of publicity with respect to blood flow restriction training, and why we're kind of arriving at this critical precipice, which is going to take us over from the early adopters and innovators into the early majority. Which is that first 50% of the population that adopts any new kind of technology. I could honestly say we were probably in the early, the innovators up until, a couple years ago, and now we're in the early adopters, or whatever the next phase after that one is. I'm just drawing a blank. Right before we're hitting the early majority, that first 18% of individuals, I think we are there. The awareness is there. Now it's about optimizing and bringing more and more people into the BFR fold, but doing it appropriately. So when we first started out in 2017, 5 years ago, BFR was all about bodybuilding. Right now, bodybuilders such as myself, when I was getting my master's degree, I was a competitive bodybuilder. I would do almost anything for gains. I would eat 6 meals a day. I would do, workout twice a day, cardio in the morning, workout in the evening, whatever. And so it kind of grew its roots then. And this is in 2017, but really we can go back to the early or the early 2010s to really track its growth, that occlusion training in the late 2000s, early 2010s, but nonetheless popularized by bodybuilding. And again, highlighting another publication talking about bodybuilding. But then we started to see, early, about 3 years ago, now celebrities are getting on board with blood flow restriction, and they're posting about it in their recovery from injury. And in just those 2-year period of time, there have been a couple of very important studies that came out of the UK that really supported the efficacy of low load blood flow restriction training. And now those high-end trainers and physical therapists start to incorporate blood flow restriction into the post-surgical rehabilitation of their celebrity clients. Continuing on in 2020, this is a great article in Men's Health. Why are they embracing blood flow restriction? Celebrities. Mark Wahlberg is actually a huge BFR proponent. He posts about it a lot. Although, he uses the B Strong bands, which are, market themselves as some sort of blood flow modulation. And that's kind of beyond the scope of this course. But in general, all blood flow restriction training is going to partially restrict arterial flow and fully restrict venous return. Or at least that's according to the definition in the literature. With the B Strong bands, they tend to just restrict venous flow. So it's a little bit of a different stimulus, and that has to do with the way that the cuff is designed. But again, beyond the scope of this webinar, what we need to know is that BFR is growing. More and more people are talking about it. And when we got to the Olympics last year, this was quote unquote like the new cupping, so to speak. But the difference between cupping and blood flow restriction training is that blood flow restriction training has, at this point, even now, despite the heterogeneity in the research, which is limiting some of the stronger conclusions, especially when we start to standardize the application of it in both, acute and longitudinal studies, are showing that it is beneficial. But when we have these systematic reviews and meta-analyses that aren't showing as strong enough effect, even or still a positive effect, or even a nothing effect, we have to consider that the state of the evidence starting in the late 90s, or really the first one was in clinical patients, was in 2000. Takarada passively applied blood flow restriction to the post-surgical limb of ACL reconstruction patients and showed that the application of the restrictive cuff alone attenuated the loss of disuse atrophy to the post-surgical side. So anyways, this was kind of, brought up. People were talking about it. Conor McGregor was posted about it with his shattered femur riding a bike. I was asked on CNN to comment on what blood flow restriction training is and why it's not just a fad and what it does and all that good stuff, which was really cool publicity for me. And if you haven't followed, or if anybody follows Chris Hemsworth, his trainer actually posted him using Katsu, which is another brand. It's actually the original BFR. Posted him doing a ridiculous BFR session, which again just illustrates that he wasn't properly trained. And believe it or not, he quit using BFR a couple weeks later because he said it was too painful. And that has to do with just an improper education and trying to do two stupid things, like trying to do high intensity exercise at BFR paired with a new client. It just a recipe for potential disaster. So the BFR pros, for example, would highly criticize that type of application because it just doesn't make any sense, doesn't align with the literature. But nonetheless, Thor was using BFR as part of some of his prep for the Thor 4 that is going to be coming out soon. And if you hadn't heard about Alex Smith and his incredible journey back to the NFL following a gruesome tib-fib spiral fracture, you should check it out. ESPN E60. He worked with Johnny Owens of Owens Recovery Science, who, I've been following his work for a while. He's one of the pioneers in North America for bringing blood flow restriction, was using it on military vets and that were getting their limbs blown off from Afghanistan, Iraq, and we're having trouble keeping on muscle and keeping healthy muscle tissue. And so blood flow restriction was kind of brought in as that low load alternative to getting results. And so there's a nice profile on ESPN E60 with Johnny Owens that I highly recommend if you're interested to check out his story, because it is crazy story. And BFR was attributed to helping him get back to the NFL, the professional football. So we cut this video. This is Dwight Howard talking about blood flow restriction and the science. I think this gives the most succinct 3-minute summary of BFR that I've ever seen. And I think this is a good introduction before we get into the next part of the webinar. So I'm going to play this for you right now.
On a night in early March, after a Rockets win, Senator Dwight Howard addresses the media. But before he leaves, Howard has one last commitment: a unique training session with Rockets physical therapist Jason Biles. It's part of a routine designed to keep Howard on the court and off the injury report.
It's good because when I'm doing the exercise, it takes a lot of the pressure off my joints. So I'm getting the same workout in, but the load is not as heavy on my knees, which is very important, especially when you get up in age.
Last season, Howard missed 41 games, many as the result of a cartilage injury in his right knee.
I had some stuff in my knee and it just kept bothering me, and every time I went to jump and move, I was like, man, I just feel this pain in my knee.
Howard really limping as he comes up the floor.
Well, I'm always jumping, always in the air, always coming down and putting a lot of force, on my feet and my knees and my back.
Blocked by Howard, rejected out of bounds.
We realized that we needed to have a plan for Dwight.
Dr. Walt Lowe, head team physician of the Houston Rockets and the Houston Texans, sees cartilage injuries as particularly threatening for NBA players.
These guys play 82 real games a year. The average guy runs about 5 miles every basketball game on a fairly hard surface.
Lowe says not all injuries require surgery, including Howard's, but there are concerns about lingering weakness of the muscles responsible for protecting the knee.
They load their knees, they load their spines, they load their body in just an exponential way compared to a lot of the other sports. And so that's where the BFR has come in to use with Dwight.
BFR, or blood flow restriction training, utilizes a specialized tourniquet cuff wrapped around the upper portion of the arm or leg. The cuff is inflated to a pressure that reduces blood flowing into the limb by approximately 80% and restricts all of the blood from flowing out.
So his max pressure is 202. We take 80%, and that's how this 161 number comes up. So that's the number, the pressure that we'll exercise at.
Are you getting the burn?
I am feeling the burn. Yes, I am.
And it only gets worse because we have 2 more sets of 15 after this.
Yeah, after this, I want to go to sleep. Oh, boy.
The decreased blood flow results in less oxygen to the limb. Exercising the muscles in this low oxygen state allows the athlete to use very light resistance, yet achieve strength gains similar to exercising under heavy loads or high intensity.
So that was a great summary of blood flow restriction training and how it's being used in elite athletics, but the same principle applies for rehab, right? In terms of seeing a surgical patient, that's how blood flow restriction works. And as I mentioned in the start of the webinar, that the demand for BFR trained providers is growing. 3-4 years ago, when I was making the rounds in New York City at some of the top hospitals in the entire world, I was almost getting laughed out of the in-services that I would be giving, because they're like, there's no way this is happening. There's no way this is safe, all that other stuff. And now myself, along with other certified, providers, are receiving referrals from these same surgeons because they've seen the power of BFR and how it has helped change their patient outcomes following surgery. That really is part of the reason why there's increased demand. Is now the time has passed and now people are seeing the anecdotal stories that are happening, as well as the published versions of those stories, the post-surgical chronic atrophic patient that we'll talk about on the back half of this webinar. And through, or right prior to COVID, we were booked. We do the in-person workshops. We have relationships with a lot of different clinic chains in the United States, mostly on the Northeast, but does spread out to the Midwest and somewhat to the South. But generally speaking, we were booked at least one course a month through February to December. And we had to cancel all of those because of COVID, and the clinicians or the clinics were trying to get their clinicians certified because of this growing demand. And it's not just isolated to the United States or North America. We were contacted and we established a relationship with one of the largest continuing education providers in Europe, and that's Kinesport. And we, through COVID, right, had to produce an online course, which we released in September 2020. And that basically was a synthesis of all of my experiences in writing the Smart Tools course, as well as taking the Owens Recovery Science, and all of my clinical experience, as well as research knowledge, and understanding that what you need at the basis of levels to be a competent BFR trained provider. And that is what this course is. Kinesport was our first international license. They translated the course into French, and they are actually going to translate the course into Spanish starting at the end of August. So that's pretty cool. And through this relationship with Kinesport, I was asked by a Kinesport physio, and they work with some of the top clubs and athletes in the world. I was asked to help collaborate on writing a BFR training program for a very, very, very high level tennis star. Can't really talk about who it is, but she ended up with a nagging knee injury, and we designed a BFR training program to help get her back to competition. And she wound up returning competitively and placed second in a major tournament the year that we programmed for her. So the same principles can be applied in elite athletes, rehab, performance. BFR is a very exciting area that is growing rapidly. I am supposed to go, for example, to Russia, barring the Russia and Ukraine war doesn't happen. And at the end of April, to discuss some of my own personal research and to give a BFR course for the Russian physical therapists. So there is demand. It is growing worldwide. So now, what are we going to cover in this webinar? Well, I think the easiest thing to do is to take you all through a surface level understanding of setting up the context for why BFR is such an effective modality in the rehab setting. So what we're going to do is I'm just going to summarize the modules 3 through 12, right? 0 through 3 are really set up and context. And I think we've covered that effectively already with regards to why BFR, why now, etc. Now we'll talk about what the course provides, the on-demand online course, that certification course, what it provides, and hopefully give you a taste of what you'll be in for when you sign up to take this course. And then the last bit, we're going to talk about a recent paper that was published last year by Dr. Frank Noyes. He is one of the most well-known orthopedic surgeons in the world, and he publishes actively, and he came out with a fantastic paper on a very common clinical problem that I guarantee almost all of you in this webinar have probably experienced in some way, shape, or form, and that is the chronic atrophic patient that's following, surgery over a period of a couple months to years later and still doesn't have that quad or hamstring back. So they published a fantastic piece that was a case series on that, and then we'll finish with some question and answers if we have time. So the course, really the meat and potatoes of the course, starts out with going over what happens when we get injured, right? We can't exercise, we can't move. There's something called anabolic resistance. And anabolic resistance is a decrease in muscle protein synthesis from our skeletal muscle not being able to upregulate the response to exercise and nutrition. And as a result of that, right, we can label that as anabolic resistance. And that's predominantly can happen a couple different ways, but for our purposes, it can happen through inactivity, and that impairs the whole process of recovery. Ultimately, what we end up seeing is atrophy or a loss of skeletal muscle size, but that is just kind of like the smoke of like where there's smoke, there's fire. Like you can see that there's atrophy, right? It's visible, you can measure it, but you also know that with skeletal muscle loss comes a decrease in bone mineral density, comes a loss of vascular adaptations, loss of tendinous adaptation. These are all things that happen in the sequela of anabolic resistance and disuse atrophy. So module 3 goes through this, goes and talks about the mTOR pathway a little bit, and myostatin and its role, a small role in the post-injury process, and what we need to do to maximize an anabolic response for our patients during exercise with or without BFR training. Module 4 now goes and talks about the power of BFR training, and the framework of this is with respect to traditional strength training and to traditional low intensity training. And so here is the main comparison that makes the most sense, which is looking at muscle hypertrophy, so muscle size, and muscle strength, which is the amount of force that can be exerted by given, movement, for example, right? And what we know from the research is that low intensity blood flow restriction typically outperforms low intensity resistance exercise without blood flow restriction in almost every single domain that we should care about as physical therapists. Talking about muscle mass, muscle size, function, cardiovascular capacity, and even muscular power. Right? There's some cool things that can happen with the unique stimulus of BFR, but then ultimately it goes in, and module 4 then talks about, okay, so if BFR is superior to what we're currently doing in rehab, how does it stack up to traditional strength training? And so it goes in through meta-analyses that look at hypertrophy with respect to heavy load strength training. It's equivocal. And with respect to strength, largely, not all studies suggest that strength, which is more of a more has to do with specificity, is greater in heavy load strength training compared to low intensity BFR. What does that mean? That means that BFR can act as a bridge to the to high intensity training for those that are able, and that's what we talk about in module 4. So how does this really set up? Like, what is this sequela? Well, then the module 4 goes in and talks about the fact that with the application of the cuff to the proximal most aspect of the arm or the leg, we are reducing blood flow to that extremity temporarily. As a result of that restriction in blood flow temporarily, we get this shift in energy metabolism, which ultimately goes from a Krebs Krebs-based cycle, right, which is very, reliant on oxidative phosphorylation, to an anaerobic glycolytic cycle, which produces metabolites, right? And that's really, really, really important because that metabolite production accelerates the onset of muscular fatigue. As a result of that fatigue, we have a slowing of the maximum muscle speed of contraction, which, according to the force velocity curve, which we're going to talk about in module 5, can increase muscle mass and strength in both type 1 and those hard to get type 2 fibers that are recruited as a result of this unique stimulus. Module 5 gives props to one of my mentors, Chris Beardsley. He is an excellent sports scientist that has really helped shape my thoughts and ideas about blood flow restriction through the use of a sharp focus on muscular fatigue. Now, muscular fatigue isn't necessary to drive adaptation. However, it is a nice surrogate, because if we know that we're getting tired, right, and our bar speed is involuntarily slowing, we know that the amount of effort that you apply to the lift is going to be a correlate to that high threshold motor unit recruitment, or those type 2 muscle fibers. Therefore, with BFR exercise, we continue to exercise, we continue to do repetitions, and as a result of that, we get this buildup of metabolites that basically reduces the absolute velocity of muscle contractions in the concentric phase. As a result of that, we need to work harder to maintain the performance of the exercise. And as a result, we get this increase in recruitment of the type 2 muscle fibers. And that will ultimately lead to, in a longitudinal training program, muscle hypertrophy and improvements in muscle strength. Now, we then segue into the force velocity curve to look at where BFR training fits. And a lot of people say BFR is kind of magic because there's all these proposed mechanisms that are here, there, whatever. And really, it's firmly rooted in exercise physiology and science, right? So if you look at this force velocity curve, right, we talk about how light loads, you can move this very fast, right? Contraction velocity, as it goes on the x-axis, contraction velocity is increasing. If you go on the y-axis, muscle force is increasing. And we can use muscle force as a surrogate for what we call mechanical tension, which is likely the largest, if not only, driver of muscle hypertrophy. Is single fiber mechanical tension. And the force velocity curve describes the relationship between a single muscle fiber and their contraction velocity, and how much mechanical tension is produced when you're trying to exert yourself at your maximum capacity. So you can see here that as BFR training, which I just substituted in low load exercise for, right? We can move a weight very, very quickly when we're not fatigued. As we accumulate fatigue from the intramuscular metabolite accumulation, now all of a sudden our contraction velocity slows, and now it goes from a moderate load to a heavy load. And as a result of that, we get this single fiber mechanical tension, which ultimately in a longitudinal training program will increase muscle mass and strength. So I say that BFR firmly rooted in science. The accelerated fatigue acts in both resistance training and aerobic training, although there is a little bit different mechanistic underpinnings in aerobic training, because you're involving hypoxia, and that can be a potent stimulus for angiogenesis. But in general, this same principle applies. Now, we talked about the million different mechanisms, and module 6 is really, we boiled it down at the BFR Pros to really 2 things. And metabolic stress is really the primary mechanism, meaning like what gets upregulated significantly with BFR exercise. And so metabolic stress is accumulated as a result of this anaerobic glycolytic process that happens. So we get this accumulation of hydrogen ions, this accumulation of inorganic phosphates, and so these interfere with the actin-myosin cross-bridge cycling. That is going to produce fatigue, and thus allow us to, with lesser repetitions, be able to get our gains, basically. And with this metabolic stress, there's an osmolarity change in the gradients between the muscle cell and the extracellular matrix. We get this fluid that goes rushing into the cell that can produce maybe anti-catabolic is a better word instead of anabolic, but anti-catabolic benefit. And thus, it's really not as strong of a mechanism as what happens with metabolic stress. As a result of metabolic stress, we get increased cell swelling. But as I mentioned before in the Takarada study, you can have cell swelling in the absence of metabolic stress. Therefore, they're independent, but they also feed into each other. And thus, that's why with high levels of metabolic stress, we are going to assume with low intensity exercise that it is a very potent stimulus for muscle growth. And everything else that happens in the body is literally a response to this high stress environment, right? Simplifying the complexity here. Module 7 is all about safety, right? It's way beyond the scope of this webinar to talk about all the contraindications, which are mostly to this point, tourniquet-based contraindications. And as I mentioned to you in the opening, our goal in the BFR Pros is to really help make BFR training more accessible and safe, regardless of whatever technology you decide to utilize in your own clinical practice. We want you to be safe. We frame safety in terms of yellow lights and red lights. And obviously you have the green light, right? Green light is healthy, no sort of issues, go. Red light, no. Red light is absolute contraindications, right? These are these are conditions that are not appropriate for BFR. And then we have to live in the yellow lights. These are proceed with caution, right? They're not a contraindication, but they might be if, for example, you have a couple of yellow lights that accumulate. Module 7 goes and talks about all of the nuances associated with the safety screening process, at least for a introductory being competent perspective. But since the publication of this course, you know, right, like we've been continuously working to improve our understanding of the safety screening process so we can maximize safety as this continues to be integrated into clinical practices worldwide. So module 7, all about safety. And then after we've gone through all of the science, we've gone through the safety, right? Then we start to talk about applications, okay? The way that we safely apply pressure is that's recommended in clinical practice is with respect to what we call limb occlusion pressure. That is the minimum pressure required to completely occlude arterial and venous flow to and from the limb. We then exercise at a percentage of that pressure. As a result of that, right, we can always ensure that we are at least during the resting state, right, not contracting, we are in subocclusive pressures. That is thought to maximize safety over other types of applications, including arbitrary pressure applications, right? So we break up our application of BFR and we stratify it into 4 pillars. Module 8 talks about the first pillar. Pillar 1, passive applications of BFR, which is cell swelling and ischemic pre and post conditioning. As I mentioned before, cell swelling is a protocol that is really not used that much, or at least, you know, in clinical practice, because as you see here, the frequency is 1 to 2 times a day with relatively, you know, higher pressures favored over lower pressures. And it's 5 minutes of passive application. So you pump the cuff up, you let it just chill, and then you deflate, and you are looking to generate a cellular swelling response. You can also, within this, add NMES, which will, you know, by essence, complement what we're doing in our own rehab plans and not necessarily replace it. So if you're doing NMES normally with a post-surgical patient, adding BFR can help maximize the stress to the muscle fiber to help promote growth and mitigate that chance of disuse atrophy. So module 8 goes and talks about cell swelling. Module 8 also talks about ischemic pre and post conditioning. Now, these are performance-based applications that have really a ton of different potential applications, but these are done at very high pressures. So 100% of the limb occlusion pressure or greater. Nonetheless, we have no idea really when's optimal to integrate this. Research is kind of all over the place, but we do touch upon the potential performance enhancing benefits of pillar 1 during module 8. I love my seltzer. I think this is my 7th seltzer today. And my girlfriend's going to kill me when she just heard that. Anyways, module 9 goes into pillar 2 cardiovascular exercise, which tends to be a bridge from the passive applications of BFR to the more active resistance training applications of BFR, where we want basically 90+% of our patients to get to, 95% of our patients to get to that can tolerate it. These are just some guidelines like that have been published in a recent clinical practice paper by Patterson et al. In 2019, that you can do, a cardio exercise 2 to 3 times a week chronically, or 1-2 times a day up to 3 weeks. The intensity that you exercise at BFR, as I mentioned, is very low. It's less than 50% VO2 max or heart rate reserve. If we did that with normal exercise, we really wouldn't see any significant physiologic adaptation. With BFR, we accelerate that or we reduce that time needed for the adaptation, but also the intensity needed due to the unique environment of BFR. We also, so module 9 basically goes and talks about all of the different ways and the considerations that we need to take into account with low intensity exercise and blood flow restriction training, with a specific emphasis on aerobic aspects. And then pillar 3 is discussed in module 10, and that is basically, again, going into the science behind resistance training with BFR. What are we looking at when we're physical therapists and we're using BFR? What are physical therapy specific impairments that blood flow restriction training can help address in order to justify its use in our practice? So module 10 goes through some of that, but it also goes through applying pillar 3 exercise or resistance training exercise with BFR. And it goes through all these guidelines, right? So you'll be able to understand what all this means as you go through the course and consume the material. Module 11 is all about practical considerations with respect to BFR and programming. So what does that mean? That means understanding the differences between what types of pressures you might apply in an exercise like this to the left that individual is doing, is more acute post-surgical, doing terminal knee extensions, versus somebody doing on the opposite end of the screen where someone's doing a reverse lunge. There is different programming things to consider with respect to position, assessment of limb occlusion pressure, and safety. So this module 11 is like the lab component, and it talks about all of that in pretty good detail. And then we have module 12, which is unique applications of BFR. These are applications that we've pulled from the literature to kind of mention, and bring to light some of the unique ways in which blood flow restriction training is challenging our understanding of physiologic adaptation. So we talk about one study that was done by Christoph Sentner in 2019 that was looking at the Achilles tendon, right, and showing similar adaptations in Achilles tendon stiffness and muscle mass and I believe strength compared to 70 to 85% of the 1 rep max, right? And since then, Sentner has come out with another paper on the patellar tendon that shows the same exact thing. So we're starting to now say, okay, we're looking at healthy tendons. Now the next step really is clinical trials with pathologic tendons, but we're seeing anecdotally some nice benefits with tendon in terms of pain, at least for me and some of the other clinicians, but also now we can look at mechanical, like physical properties of the tendon and be assured that they are going to adapt similarly to traditional loading recommendations. And then module 12 goes into pain, right? What does BFR show with respect to reducing pain? Because that is a very big application of blood flow restriction. We wrote about that last year in our perceived barriers paper. You either have, in order, like right now, the literature is such that if you either have a pain problem or you have a loading problem, and a loading problem could be from a safety perspective, it could be from post-surgical precautions, it could be from any other different considerations, or pain. Those two are justified to get that patient into that clinical thought process algorithm that we call the funnel of BFR training. So we talk about pain, and then we also talk about a study that was preliminarily published ahead of study completion out of a lab in Texas that was looking at post-surgical rehabilitation of ACL clients, and showed that not only is there atrophy, which is partially attenuated with the use of BFR compared to no BFR, but they also showed like no loss or minimal loss of bone mineral density in the distal femur, proximal tibia, and fibular head, which the non-BFR group showed significant losses in. And that study, which we talked about in the course, is, still decided to collect more data because they wanted it to be an even stronger result. But not only that, those individuals also cleared return to sport testing 7.5 weeks earlier than the non-BFR group. Not saying that we're discharging patients early, but we maybe have with BFR, because we accelerate the early parts of that rehab, either through reduction in pain, improvement in muscle performance, whatever, that now we can spend more time in rehab on that high functioning aspects of care. And then last, we talk about performance, right? What has BFR done in terms of augmenting sports performance? And that looks at a study in the journal Strength and Conditioning that basically showed an increase in jump height with the acute application of 3 sets of 8 lunges in BFR prior to a max jump height test. So a lot of cool things that we're learning about BFR that are challenging our understanding of physiology. So I guess we can pivot into the paper that I want to discuss before then ending on any questions. And I chose this paper because number one, it's in our in-person workshop because it's so important. It was published last year and by a prominent orthopedic surgeon. And, it's titled Blood Flow Restriction Training Can Improve Peak Torque and Strengthen Chronic Atrophic Postoperative Quadriceps and Hamstring Muscles. This is the study that basically validates a lot of what we've been seeing in clinical practice anecdotally, which is that we're kind of being able to help these patients with longstanding atrophy be able to get rid of it, where traditional training has failed. The big thing to highlight here is that this was published in Arthroscopy, which is a physician-read journal. Physicians don't give a crap what physical therapists publish. They really don't. And I can tell you firsthand, what they care about is BFR published in their journals. And what we're finding is more recently is more and more studies are mentioning BFR or are actively investigating BFR or writing reviews about BFR in these physician-led journals. For example, in Arthroscopy, in January, there was 3 articles that were BFR related. One was a mention of BFR and post-surgical ACL rehab, and 2 others were mentioned. Number one, kind of like a summary, a clinical summary of BFR, and then the proximal benefits of BFR, meaning can you get glute gains from doing BFR on the thighs, right? Short answer is it's complicated, but nonetheless, it serves as a vehicle to increase the exposure of blood flow restriction training. Not only that, there was another editorial that was written by Dr. Robert Laprade, which is another big time surgeon that also voiced his support for not only the study, but also echoing the positive benefits that he's been seeing in their practice with their post-surgical patients and chronic atrophic patients to get them back to the activities that they love as quickly as possible, right? And where traditional physical therapy has failed. So with that being said, contextualizing the problem that we face in rehab is there are significant there is a significant prevalence of atrophy and strength loss that follows ACL surgery. For example, in this one snippet from Thomas in 2016, quadriceps cross-sectional area was strongly related to muscle strength 6 months after anterior cruciate ligament reconstruction, and substantial injured versus uninjured limb deficits were demonstrated for strength and cross-sectional area, meaning that keeping the quad cross-sectional area is important for the expression of strength. This can be an issue because if we're not able to load them early, we get that AMI, arthrogenic muscle inhibition, and thus now we're working uphill, maybe up a mountain instead of up a hill, right? We can reduce the barrier to getting them that positive post-surgical outcome. And further, traditional rehab has challenges, right? Getting the patients, to come in on time, making sure their insurance is appropriate, making sure that we're challenging them, like with our protocols, getting them to a level of exertion that is needed in order to build strength and combat atrophy is essential. This is what this chart is kind of showing in this, or this picture is showing here. It's that when you have BFR, you need to be comfortable with the muscle pain that you're going to produce. It's not going to be comfortable. And we talk in the course about the 3 hurdles of BFR training success in order for you to be an exceptional and competent BFR trained provider. The first is understanding the science of hypertrophy, right? That is really important. Then it's understanding the safety, and then it's understanding the having effective communication through all of the aforementioned. If you can negotiate those 3 hurdles, you're going to be an exceptional BFR trained provider and have a ton of success. And that's why we laid out the course in the manner that we did, is because I'm telling you through practical experience and seeing what else is out there, as well as consultation with other experts. This is the best way for you to get comfortable with blood flow restriction. That means that when you are working with a patient, when they're like, oh my God, my leg is on fire, right? That's not something that is unheard of with BFR training, because it is uncomfortable. You are getting those metabolites that are stimulating the basically pain reception in that area. And so it's communicating with those patients to say, hey, listen, this is good. This is something that, is basically signaling that we're helping to build muscle, right? And then the challenge of doing so, knowing that some patients are very, oh my gosh, I have a little bit of pain. Like, we're physical therapists. We are across the board known for underloading our patients, right? Where we don't know, we basically are like, oh, don't do that if it has no pain or whatever. But again, think about it. Muscle pain and joint pain are completely different, right? Muscle pain from metabolite buildup is different than joint pain, right? But at the end of the day, we have fear of losing patients if we challenge them too much. So understanding all of what I just said and being able to communicate that with the patient and be able to meet them at their level by modulating the potential stresses of BFR exercise is going to help you almost guarantee your BFR training success. So who were these people in this study that they did? They took 27 chronic post-surgical knee patients with greater than or equal to 20% difference in their unaffected side, right? Where they had a unaffected hamstring or quadriceps loss of strength greater than or equal to 20%. Or they had a 2 centimeter or greater thigh muscle atrophy compared to the opposite extremity, right? So they had a strength loss, or they had a muscle mass loss, and they had to agree to complete at least 9 BFR sessions. right? So there was 9 sessions and 18 sessions, 3 times a week. So this is a 3-week program. Keep that in mind. The exclusion criteria were pregnancy, history of varicose veins, history of DVT, PEs, use of oral contraceptives, history of myocardial infarction, stroke, unstable heart disease, and use of heart medications greater than 140/90 BP, and cardiac disorders of any type, including tachycardia. If you note here, these are very common, what we consider contraindications to BFR training. Do I think they're absolute contraindications in some cases? Not really, but from a public education perspective, these are some of the more well-known contraindications to BFR training, if you're wondering about the safety aspect. So here is just looking at the spread of patients here, looking at 18 females, 9 males. They looked at 17 knees, 17 right knees, 10 left knees. The average age of the patient was about 40 years old. They were about 241 days post-op, but noticed a large standard deviation. So there was people that were way beyond that as well. But they had on average 22 plus or minus 10 physical therapy sessions before, and they were in physical therapy for about 5.5 months. So they were doing a lot of physical therapy and were not having as much success getting rid of that atrophy. 27 individuals completed 9 sessions, while 14 completed 18 sessions. And BFR was done for the quadriceps and the hamstrings on 16 individuals, the quads on 10, and the hamstrings on just 1. If you notice to the right, it's a very heterogeneous sample of chronic atrophic knee patients. I'm sure if you look at this list, you probably can think of 1 or 2 patients on your docket that has had one of these surgeries. But again, it was nice because this was heterogeneous, right? It wasn't just one particular type of patient that this study looked at. And so what do? They looked at 2 to 3 sessions per week, which mostly was 3 sessions per week. They accumulated either 9 or 18 sessions of BFR. And what they did was they looked at 4 exercises with BFR using approximately 30% of the 1 rep max in a very standardized repetition scheme of 30 repetitions on set 1, followed by a 30 to 60 second rest on between set 1 and set 2, and then followed by 3 sets of 15, each with that 30 to 60 second rest in between. And they applied BFR with around 60 to 80% of the limb occlusion pressure, right? So not the 100%, but 60 to 80%. And what they wanted them to do was report about a 7 out of 10 muscle burn as a result of the exercise. If it was more, they reduced the pressure and or the load. If it was less, then they increase the pressure and or the load. So they make sure that individuals were exercising in roughly between that 7 out of 10 muscle burn. And so you saw these 4 exercises: leg press, hamstring curl, leg extension, and mini squats. And they rested 2 minutes in between sets. And also what I thought was awesome in this study design is they asked the clients to rate their perceived satisfaction and efficacy of BFR training when compared to traditional physical therapy. So now we have their thoughts and their beliefs on the efficacy of BFR training without understanding any of the results. So here is just looking at some of the pre-post strength and limb circumference. You can see here that individuals had sometimes greater than 40% deficit side to side. That's terrible. Hamstrings were not much better at 38. And if you go even further into the longer study, like longer duration intervention, you have almost 50% side to side deficit. Again, terrible. And then if you look at the pre-training limb circumference, is about 49.8 and 42.5, right? They were taking it. They took 5 centimeters suprapatellar and 15 centimeters suprapatellar. Now, what do we see? We saw that there was a significant increase in or a reduction in the deficit to the limb following 9 and 18 sessions of BFR. Now, note again, this is 3 weeks and 6 weeks of BFR training, basically. Right? This is not like a 12 to 16 week program. So the fact that they went from such a large deficit to now down to 36%, and in the hamstrings 22%, and in the quadriceps they had a very large effect size with as well as in the hamstrings. Like looking at effect size of 1.31, that's massive, right? That is huge. Now, again, their deficits are still large, but 50+% had improvements greater than 10% in quad to hamstring torque following 9 sessions, and 20%, greater than 20% had improvements after 18 sessions. All right, that's huge. Here are kind of the schematics of that study. So if you look really, you can, again, the graphs kind of speak for themselves, showing that that individuals that utilize BFR that improved after 9 sessions, 69% of the included study individuals in the study improved at least 10%, while 31% improved less than 10%. But then if you increase that to 18 sessions, 86% of the patients in the study improved and 14% did not improve, right? And then you go to the hamstrings, it's 3 to 1. So 75% improved greater than 10%, and 25% improved less than or equal to 10%. And you carry that out to the long term, and you see that now between 10 and 19%, you have 12% more. So again, hamstrings looks like it's a little bit harder based on the data shown to improve the limb symmetry, but nonetheless showing positive benefits in that short 3 to 6 week intervention. All right, and then here's just another slide talking about muscle strength deficits after. Not going to really spend any more time on that, but again, just note that there is improvement with the with BFR, generally speaking. The more you do it, and in this short period of time, we still saw some significant results. What wasn't significant was any changes in limb circumference. So you see that if you look at pre to post training, there really wasn't any difference at all in the limb circumference. And that might be due to the fact that limb circumference is a pretty terrible, has pretty terrible sensitivity for changes in muscle size. And so, you know, it might not be in this situation that that we could observe a benefit. Maybe if the duration was longer, or if they utilized MRI, but they really tried to make it clinically relevant by using the methodology that they did, which was, you know, isometric torque, isokinetic, etc., or peak torque for isometric. I don't believe they used isokinetic, but I might be misremembering. Nonetheless, the perceptions of the patients following BFR training, patient satisfaction was scored at an 8.9 out of 10, right? With a range of 4 out of 10, meaning that the vast majority of individuals found that they had satisfaction with BFR training in their plan of care. 63% believe that BFR training produced superior outcomes to traditional training, while 37% believe BFR produced somewhat better outcomes. Notice that nobody had any negative responses to to the BFR stimulus in terms of their perceptions of whether or not it's efficacious related to traditional strength training. There was no serious complications with BFR reported. There was one report of post-exercise muscle soreness, which again, DOMS is a very common response when you first start any sort of new exercise training program, not just BFR. So this is not any different. So what are the real takeaways from this case series? Well, as I mentioned before in introducing this, Dr. Frank Noyes is a well-known orthopedic surgeon. And this manuscript was published in Arthroscopy, which is a major orthopedic surgeon journal, and thus are going to get a lot of physician eyes on the outcomes of this study. And the outcomes of this study indicate that BFR is able to succeed in augmenting muscle strength gains where traditional physical therapy has failed, right? The average individual in this study was in physical therapy for 22 sessions over 5.3 months. And so you saw the initial injury occurrence, which again, these could be all those chronic rehabbers that are just not able to get out of the downward spiral that they found themselves in following surgery, and maybe a poor recovery of their rehab, et cetera. So this is a really awesome study to have in your back pocket when you talk to physicians, because it checks a lot of the boxes associated with how I would anticipate a successful clinical integration of BFR is provided. This study will, said BFR is well tolerated with minimal adverse events. People think that BFR is more effective, and my addition is, and it is better for results. BFR, blood flow restriction, better for results than traditional therapy without BFR. Then, as I mentioned before, the muscle size changes likely occurred, but not picked up due to the sensitivity of the outcome measure and the easy to integrate protocol of 7 out of 10 discomfort to gauge this pressure load to the limb. I think there's a lot of cool things to integrate and take away from a study like this. And even more so, in their actual conclusions, Dr. Noyes said the extrapolation of the results of the current study and the overall promising results of blood flow restriction training in other studies has led to the adoption at our center of a blood flow restriction training program after all major knee operative procedures beginning at 3 weeks post-operative. So they wait 2 weeks and then they begin BFR training on the 3rd week. That is probably some of the strongest language from the research perspective from a very prominent surgeon. And if he's seeing results and he's putting his name behind this technology, then you really should start thinking about integrating this technology into your own practice. Now, let me summarize this webinar for you. The demand, I hope, as I've tried to convey, for BFR training is rapidly growing due to previously only anecdotal stories that are now being shown through peer-reviewed studies. Physicians are now looking for individuals that are certified in blood flow restriction because it is a tourniquet. You are applying this technology to a patient that may or may not have comorbidities. So we need to respect the physiologic response to exercise with BFR, right? So it's important to get trained in this technology, even taking an online class like the one that we produced, whether you decide to take our class or not, getting trained is very important from a legal perspective. And we come out in our paper, safety screening paper, saying that that just because blood flow restriction is within your scope of practice doesn't mean that you are competent to administer it, right? And how do you get competency? You get it through post-professional education or curated study of the research. And so a course like the on-demand course, the introduction to BFR training, will give you everything that you need to know regarding use of blood flow restriction in your practice. Now, the next step is, okay, you've gotten trained in blood flow restriction, but where are people going to go to find you? Well, we've created an unbiased resource, right? Because again, the mission of my company is to grow BFR training worldwide. So this is not even affiliated with the BFR pros. It's called bfrproviders.com. You can put it in your web browser right now. We just launched last week. So we have like 50 plus people there, but basically it's a vetted search engine. So in order to be listed, you need to upload a certification from a certification provider or an education provider that gives specific post-professional education and blood flow restriction, such that when physicians are now looking for their patients to go see a provider that's certified in BFR, this is where they can find them. So as you complete the course, you can now market your services on bfrproviders.com. And as the demand grows, you'll be there to meet it and basically, you know, be able to market yourself. And at the end of the day, which is probably the most important thing, is improve your patient outcomes. Last, because we created the course in September 2020, and believe me, the course is still just as up to date as if it was published yesterday. Nothing has really come out that has changed anything regarding the content of the course. In fact, research has now come out to support what I say as a theory. In proposing some of these strategies have actually come out to be more supported in the literature, which is awesome. Nonetheless, in April 2022, we're shooting to give free content updates for our course. The first one, which is going to be what's new in BFR in 2021, right? We're going to talk about the noise study. We're going to talk about a couple of other studies, my perceived barriers paper that we talk about in terms of the screening process. We'll take you through that. And so you get free content updates just for purchasing the course whenever. So if you purchase it in September of 2020, you'll get what's new in 2021 as part of your free update. And that will continue every year. We'll have a new update to the course to make sure that you're getting the most up-to-date vetted information from the BFR pros as to what's going on in the BFR landscape. And second, in the end of March 2022, we are launching the Master Series of courses. This is going to be a paid edition. This is about a 90-minute module where we're going to go through 5 published case studies on blood flow restriction training that's been in the literature. We're going to critique them, and we're going to talk about post-surgical safety screening. How do you assess for DVT? What is the bare minimum competency that you need to have? And really just make sure that you're prepared to be a successful, confident, trained BFR provider. So with that being said, look out for that Master Series launching in March, and in April, if you move forward with the course, you'll have access to that update lecture. I know that was a lot, but I wanted to just say thank you to Ben for having me, and any questions on what I talked about, and let's go.